Hi, welcome to the presentation, Dementia-Related Psychosis, Conceptualization. Acute onset of psychotic symptoms, we should consider them as acute pain plus delirium, meaning that people with dementia are in severe emotional distress, like acute pain, and also are in delirium, which is a medical emergency. So they really need comprehensive assessment as soon as possible. Chronic psychotic symptoms in individuals with dementia, we need to manage as chronic non-cancer pain, meaning that we need to minimize antipsychotics. We need to think of dementia with psychotic symptoms as a secondary psychotic disorder, and we need to rule out, say, schizophrenia, bipolar disorder with psychotic symptoms, major depression with psychotic symptoms. We also need to rule out delirium, metabolic causes of psychotic symptoms like electrolyte imbalance, dehydration, infection, nutritional deficiencies. Even medications can cause psychotic symptoms. And obviously, you can have both. You can have a primary psychotic disorder such as schizophrenia, and they live long enough, and now they develop a secondary psychotic disorder such as dementia with psychosis. For example, they develop strokes and then develop vascular dementia on top of schizophrenia. Why bother? Psychotic symptoms can be extremely distressing to the person with dementia and not only cause severe agitation, but even violence and suicide. I had one patient who jumped out of the second-story house because of the psychotic symptoms and sustained subdural hematoma. Also, psychotic symptoms in dementia people are often inappropriately managed with antipsychotics, and antipsychotics are very dangerous drugs, have serious side effects. So we need to really minimize the use of antipsychotics in individuals with dementia, even those with psychotic symptoms. Also, 50% of older adults with dementia will develop clinically significant psychotic symptoms. So that's really common. We're talking about 5.4 million Americans right in our country who have dementia, and half of them eventually will develop serious psychotic symptoms. In the world, there are 50 million individuals with dementia. So this is really a big deal. Also, in older adults, psychotic symptoms due to dementia are way more common than schizophrenia. And as I mentioned, antipsychotic use in older adults with dementia exceeds the antipsychotic use in schizophrenia in older adults. When I say there are psychotic symptoms, I mean that they have either delusions and or hallucinations. In clinical practice, even catatonic symptoms could be considered psychotic symptoms, but I would consider them as a separate condition. Typically, the psychotic symptoms one sees in dementia people are paranoid delusions, such as they're convinced that somebody's out to kill them. I had one patient today who was convinced that I had met him before, I hadn't, convinced that I was part of the organization that is sabotaging his move from Idaho to California. So again, these are very serious symptoms. He has been threatening to kill the staff. So these are not to be taken lightly. Many individuals with dementia develop grandiose delusions, delusions of infidelity, which can lead to domestic violence. So it's important to recognize all these different types of psychotic symptoms that may happen. Hallucinations can not only be auditory, but actually they are more commonly visual, tactile, olfactory, gustatory, and multimodal hallucinations are quite common in people with dementia. Dementia with Lewy bodies, eventually 90% of them will develop psychotic symptoms. Parkinson's disease dementia, 50 to 80%. Alzheimer's dementia, vascular dementia, 50%. Frontotemporal dementia, maybe 10%. So again, it's important to know the cause of the dementia, and then the treatment will be different. In Alzheimer's dementia and vascular dementia with psychotic symptoms, we do not currently have established criteria, but Gerontological Society of America has come up with a superb document, and I would urge you to look into that to understand more. Psychotic symptoms due to Lewy body dementia, again, the criteria are not established, but visual hallucinations are very vivid, very prominent. I have one patient who's convinced that the small children are entering his room, sitting on his bed, and he's even broken the bed to kick them out of the room. Again, these individuals have unique neurological problems, so these people can be very reliably diagnosed, and then the treatment is very different for Lewy body dementia, say, compared to Alzheimer's dementia with psychotic symptoms. The four key interventions for dementia-related psychotic symptoms is: number one, you do a psychosocial spiritual wellness care plan. Number two, rational deprescribing, where you remove medicines that could be causing or contributing to their psychotic symptoms, agitation, neurocognitive issues. Many a times I identify infections, dehydration, electrolyte imbalance, nutritional deficiencies, thyroid dysfunction as cause or contributors to psychotic symptoms. And once you correct these reversible medical conditions, the psychotic symptoms are much more manageable. Staff and family need to be educated and trained and supported in how best not to argue with somebody who has dementia with psychotic symptoms, and how to validate their feelings, how to reassure them and then distract them. In some people with dementia with Lewy bodies, there are studies to show that cholinesterase inhibitors such as rivastigmine, donepezil may reduce psychotic symptoms. So again, we can avoid antipsychotics. There's even one study where citalopram has been found to reduce agitation related to psychotic symptoms. So again, we could consider that, although it's not approved by the Food and Drug Administration. Parkinson's disease psychosis is now an established condition which has a set criteria, and now we even have a new drug called pimavanserin, Nuplazid, that is approved for treatment of Parkinson's disease psychosis. Very costly, but at least we are making some progress. Delirium is very common in the elderly. Psychotic symptoms are very common in delirium, and the treatment involves treatment of the cause of delirium. Again, infection, electrolyte imbalance, and so on. And we need to really avoid or minimize the use of antipsychotics in treating psychotic symptoms related to delirium. Collaborative care practice is what I do every single day, and I would urge you to start doing it, where psychiatrists collaborate with primary care physicians, consultant pharmacists. We have a team-based approach. We have family members involved, staff involved, and this way the success rate skyrockets in terms of effectively managing psychotic symptoms in dementia people. Again, the risks of antipsychotics are incredible, including strokes, premature death, neuroleptic malignant syndrome, and a whole long list of other risks. So let's try and do what we can to minimize the use of antipsychotics in individuals with dementia with psychosis. The best intervention would be to consult a recreational therapist. They can see the person, get details, and then create an individualized psychosocial spiritual wellness care plan that involves, say, daily Skype interactions with family members, hand massage with lavender lotion, various spiritual, religious activities that can be very soothing. Atul Gawande, in his book, Being Mortal, superb book, has said this: we are caught in a transitional phase. However miserable the old system has been, we are all experts at it. We are all experts at giving antipsychotics. We know the dance moves with this new way in which we together try to figure out how to face mortality and preserve the fiber of a meaningful life with its loyalties and individuality. We are plodding novices. At this point, we are plodding novices in creating a superb psychosocial spiritual wellness care plan. We are going through a societal learning curve, one person at a time. It's really important for us to keep learning and keep doing the right thing. I strongly recommend my own book that I wrote with Dr. George Grossberg. Dr. Grossberg is a nationally, internationally renowned geriatric psychiatrist. We have a whole chapter on rational deprescribing, another chapter on psychosocial spiritual wellness care plan. Again, Gerontological Society of America came out with a superb document, Dementia-Related Psychosis, in August of 2019. Check it out. An American Psychiatric Association has come out with practice guidelines for the use of antipsychotics to treat agitation or psychosis in dementia, check that out. Bottom line, dementia-related psychosis needs to be taken seriously and assessed comprehensively. Successful treatment of psychotic symptoms can be life-saving, and psychotic symptoms are eminently treatable with rational deprescribing, optimal treatment of medical and neurological conditions such as pain, psychosocial spiritual wellness care plan, and family staff training and support. Thank you for your attention. Hope this has been useful. Have a great day.